Today's video will be looking at biomechanical examination of the ankle, the hip, the shoulder, and then we'll also introduce a more detailed concept of etiology searching and relating that to the diagnosis of the presenting complaint. You'll get much more of this as the course goes on, but this is not a bad time to introduce this and make you start giving some thought to that issue. The ankle. Let's preface this particular joint anyway, if only this one, with the biomechanics of the ankle. So we have a modified sellar joint, 1 degree of freedom, plantar flexion, dorsiflexion, conjunct rotations are medial rotation for plantar flexion and lateral rotation for dorsiflexion. The direction of the glide is anterior for plantar flexion and posterior for dorsiflexion. So this is the talus, talus moving underneath the mortise, and the talus presents a convex surface for this. So the close pack position of this is full weight-bearing dorsiflexion. I'm not sure we'll do this with the other joints, but just I'm doing this to make sure that you continually think about the relevant biomechanics. So we'll start off with our forgetting screening tests now. We'll go straight into the proper examination of the ankle, biomechanically speaking anyway. So the passive physiological movement is plantar flexion, dorsiflexion. And I'll come back to the talus swing in a second, but this is an alternative to doing straight plantar flexion, dorsiflexion. And this will either produce hypomobility or hypermobility. If there's hypermobility present, we do the stability test, which not biomechanically really doesn't include the ligaments as such, but probably your best stability test, biomechanically speaking, is to try and distract the joint while it is in dorsiflexion. You should be able to do that. Nor should you be able to shift it from side to side or forwards and backwards while it's in dorsiflexion. If it's hypomobility, then you do the PAMs. So as I say, for plantar flexion, it will be an anterior glide. For dorsiflexion, a posterior glide. Now, the talus swing test can be used as a screening test, although the other screening test for this is weight-bearing plantar flexion, plantar flexion, dorsiflexion, so squatting over your toes, coming up onto your toes, and inversion, weight-bearing inversion and eversion as you twist. The talus swing test is done with the patient sitting with a leg overhanging the bed. You palpate the medial talar tubercle with one index finger. The other hand finger wraps around the back of the fibula, and you put your thumbs on the neck of the talus and support the foot you support the foot with the other finger. So you then swing the knee. You move the leg forwards and backwards so the knee is extending and flexing. And as you do that, the ankle will do that as well. But you've got to keep the sole of the foot parallel with the ground. Otherwise, you'll just sort of swing the knee. So as you push it in, it goes into dorsiflexion. As you pull it out, it comes into plantar flexion. So you're looking at the range of motion, but mostly it's about the infill that you're gaining from those two ranges. The fact that the talus does slide forwards and backwards, and you feel the neck disappear as you go into dorsiflexion and press against your thumbs as you come into plantar flexion. And equally as important is you feel that talar tubercle move against your finger and away from it as the talus rotates in the mortise during plantar flexion. So it's a more combined test. If you do that, then you really don't need to have to do the PAM, because the PAM is part of that talus swing test. Now the hip, passive physiological movement. Done properly, you will stabilize the innominate so that you can move the femur under the innominate without pushing the innominate with it. So when you stabilize it for extension, you'll push down on the ischium, not on the ilium, because you're going to push the ilium in the direction you don't want it to go if you do that. So push down on the sacrum, and you basically lean over as you bring the hip up, or the femur up, and that will give you good extension. You'll see the range limitation is so much more when you stabilize properly than if you push down on the innominate, because when you push down on the innominate, you're of course extending the lumbar spine and you're moving the SI joint. For flexion, you'll stabilize it so that it can't basically rotate backwards. The innominate can't flex as you flex the femur. Medial lateral rotation, if you're doing it with the hips in extension, that is a patient laying prone. You can do, certainly for medial rotation, you can do both legs together, but you have to stabilize the pelvis to get an idea of whether this is a PPM for the hip or whether it's combined with the SI joint and the lumbar spine. So stabilize the pelvis. If it's hyper, the chances are it's going to be muscle that's allowing it to become hyper, so you have to give some thought to that. Otherwise, you can stability test this. Again, you can try and close pack it and distract it. Otherwise, this is quite difficult to stability test. Probably your best bet there is to use quadrant testing and feel for a consistent click or clunk or a consistent hypomobility in one direction and normal range in the other. For the PAM, distraction, put it in the least pack position so the hips flexed, a little bit laterally rotated and abducted, and then try and distract it. And you're looking for normal infills on both sides. If the capsule is tight, it's hypertrophied, then you'll feel that as a stiff movement. You can't do glides up and down with this. The joints are too congruent. If the laburnum's intact and the articular surface is intact, then you can't glide it. The problem you've got is trying to fill the glides as a glide rather than the whole pelvis movement. So this joint can be a little bit difficult to stabilize for both the PPM test and the PAM. Radiohumeral joint. Remembering that, like the hip, this is an unmodified ovoid, so it will have 3 degrees of freedom: flexion, extension, medial lateral rotation, and abduction. Again, flexion, extension are like the shoulder. These are spin movements, while the other two are swings. So again, you have to stabilize the scapula if you're going to get any idea of the proper PPM, and you'll learn this as you go. But you must stabilize the scapula so that you can more or less isolate the movement to the shoulder. You can't do it completely, but you can get close to it. If it's hyper, stability testing, again, you can close pack this in the, you can distract it in the close pack position, which is lateral rotation and abduction. Or again, you could do quadrants, which is the same thing as you look for in the hip. If it's hypo, then your glides will be, for flexion extension, will be distraction, again, in the least pack position, abduction, inferior and superior gliding, lateral medial rotation, anterior and posterior gliding, all of that respectively. So let's do a complex, elbow complex. So we start off generally with the ulnar-humeral joint, it's usually the most important joint, and our PPMs now will be flexion, supination, extension, pronation, ab and adduction. Now, you're familiar with this joint anyway because we've talked about it previously. So it makes it a lot easier for everybody. So that if it's hypo, then you will do PAMs, and respectively there will be an anterior arthrokinetic, posterior arthrokinetic of the ulnar-humeral joint, and probably more important biomechanically, in fact I know more importantly biomechanically, is lateral and medial gliding for ab and adduction. The PAMs for flexion and extension of the ulnar-humeral joint will be present when you've got either arthrosis, arthritis, or you've got adhesions following a fracture. So most biomechanically, it's all about ab and adduction. If it's unstable, then we can look at ab and adduction in the closed pack position. So you put the ulnar, the elbow into extension pronation, and then see if you can ab and adduct it, and you shouldn't do. And again, you can use quadrants the same way as we used them previously. For the radiohumeral joint, we've got basically 2 degrees of freedom: flexion, extension, pronation, supination. So The PPM is going to be flexion pronation, because that will bring the radial head up as far on the capitulum as it can, and extension supination, which will take it down as far down the capitulum as you can. Now, the end fills here are different from the end fills in the ulnohumeral joint. For extension and supination, this will not be a bony end fill as it would be with the ulnohumeral joint. It will be capsular, and quite strong capsular end fill at that. For pronation and supination, it's just that. Pronate and supinate. The PAMs are a superior glide for flexion, an inferior glide for extension, and distraction in neutral. For the stability test, it will be distraction, extension, and again the quadrants. The superior radioulnar joint, we can do a PPM, which will be pronation and supination. The PAM will be dorsolateral. This is a superior joint now. Dorsolateral for pronation, ventromedial for supination, and the articular stability test will be quadrant testing. For the inferior radioulnar joint, it's pronation, supination again, obviously. Your PAM now will be ventromedial for pronation, dorsolateral for supination, and for the AST, you're going to be grinding these two joints together, looking for it to be clunking and clicking and grating. Let's look at the shoulder complex. So glenohumeral joint, again, you must stabilize the scapula. We discussed this earlier. We've done the basically the glenohumeral joint. For the articular stability test, sorry, I've got SST there. For the articular stability test, this would be the Jones shift test, O'Brien's, anterior and posterior gliding now, not anterolateral and posterolateral, but straight anterior, posterior. Whereas if you look up at the PAM for the glenohumeral joint, it's in the plane of the joint. So this now becomes anterolateral, posteromedial. But these two are in the plane of the joint. You can also, of course, use a quadrant testing. For the acromioclavicular joint, your PPM is to protract, retract, elevate, and depress the shoulder girdle now. You don't do it with, well, you can do it with the arm, but it's mostly about moving the shoulder girdle. For the SST for that, this will be an anterior, posterior, inferior, superior glide. For the PAM, it'll be posteromedial and anterolateral, and still inferior and superior, but you're looking for different things now. For the PAM, you're looking for a reduction in movement. In the SST, you're looking for increased movement, noises, and so on. And again, the quadrant test can be used for this. The quadrant test, I won't tell you what joint's in trouble in this type of complex. For the sternoclavicular joint, which doesn't get bothered too often, the passive physiological movement, again, is protraction, retraction, elevation, depression, and rotation. This is part of all of these movements. The clavicle rotates backwards and forwards with all of these movements. We're going to test it as if it's a separate degree of freedom. I don't want to get into the biomechanics of this joint, but you've actually got two joints in one. You've got the claviculo-meniscal joint and the meniscosternal joint, and they behave differently, but more of this later. The PAM, the SST, will be anterior, medial, superior, and inferior, not these diagonal glides that you do through the plane of the joint. So the PAM now is anterolateral, posteromedial, inframedial, supralateral, and again, distraction for the capsule. Okay, so we're going to go into a little bit of advanced stuff now, advanced from this course, but I think we can introduce it here without too much trouble. We're going to be looking at a particular degenerative condition, a degenerative label test. So you do all the diagnostic stuff, and this is what you come up with. We can look at causes and effects. So if we look at what causes this, these are some of the more common reasons for it. C56 segmental facilitation. Now, this is prolonged nociception from any tissue in that segment, not just the neck, all right, but it often is the neck. So this is a neurophysiological effect causing segmental facilitation, which in turn causes weakness, and then of the stabilizing muscles around the shoulder, and so you end up with the labrum taking a beating. What should be happening is these muscles should be stopping the translation, or at least severely limiting the translation during active movements. So as it's not doing that, you get extra translation going on, and it beats up on the labrum, and the labrum gradually degenerates. It can cause flexion subluxations of the upper T spine, the upper T spine flexion subluxations can cause degenerative labral injuries. So, and the first and second upper ribs, because when you elevate your arm, retract your arm, or any of this stuff, these joints have to be able to extend to basically take part in the whole process of elevation. The faster these movements occur, the more ballistic that is, then the more chance there is of damaging the labrum. So throw-in athletes and so on, but anybody who's repeatedly bringing their arm up over elevation fairly rapidly. So this can be caused by mechanical stress, inability of the vertebra or the rib to extend and take part in elevation movements. As I say, it's got to be able to play its role. If it can't play its role, then there's more stress applied to the other tissues, which could be the labrum. Or this can be neurophysiological, segmental facilitation from pain there, and also a sort of a secondary reflex inhibition from the dysfunction at these joints, causing weakness of these muscles. AC joint can get can cause this problem as well. So to elevate the arm, the AC joint has to be able to glide anterolaterally. If it can't do that, then there's increased stress in other components of this movement. So this will cause mechanical stressing of the labrum, for example. Or it could be neurophysiological again. So if the AC joint is in pain, then segmental facilitation causing the problem. Or again, it may be causing reflex inhibition and then weakness around the shoulder area. Effects of this in other tissues, it can overextend the thoracic spine. So if the shoulder can't fully extend, which a hypomobile shoulder called bilabral impingement, if that can't fully extend, and these are not really uncommon in my experience, then you're going to start stressing out the thoracic spine, and one or more segments are likely to start subluxing into extension. You can also cause tendinosis of the glenohumeral stabilizes by mechanical overuse, because the shoulder is unstable. These things may work harder trying to stabilize it. Or it can be neurophysiological with reflex inhibition, segmental facilitation, again causing weakness and tone changes. What you can also get is direct instability, causing stress if the glenohumeral joint is hypomobile. So this can cause instability of the AC joint, again by mechanically overstressing it. So a very brief, little more comprehensive introduction, rather than just mentioning these things that we've been doing, into etiologies and effects of this particular dysfunction. All dysfunctions that's bringing the patient in to see you that doesn't have an obvious cause has this same thing going on. There is something that's creating the problem. It just doesn't appear out of thin air. So often these things are asymptomatic and you need to go looking for them. The only way you can do that is by basically knowing what the diagnosis is, knowing what mechanical, neurological and neurophysiological stresses may be creating the problem there, and then going and looking for them specifically.